First,
Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas from Tehran, and once again, I'm so grateful to have the chance to be with you all from this educational platform. And I have to say, as always, I'm so blessed and honored that so many great speakers and researchers and educators accepted the invitation and are joining us from this platform. And I think it's a very, very good opportunity for all of us to learn from the best in the field of perio, implant, prosto. So I think it's going to be so much fun. And today I have a very dear friend, a very, very demanding speaker. Dr. Luigi Canullo is here with me from Italy. And first of all, I would like to have a welcoming chat with him, and then we will go to the presentation. Hello, Luigi, and welcome to Hot Seat, my friend.
thank you so much. Thank you for the invitation. I'm so glad to be here. So let's start.
Yeah. Dr. Luigi Canullo is one of the amazing speakers that you've all seen him on the biggest platforms in different congress symposiums. And also, I have to say, he's the author of one of the greatest books I've ever read. It was published by Quintessence in 2012. It was Peri-implant Tissue Remodeling. So I really recommend it to all of you because, you know, I was graduated in 2010, and that was one of the really recent books that I received during that time, and it really changed my insight. And I really recommend it to you all if you're interested in biology and how bone deals with the implant and how you can control everything in your hand for better practice. So first, I would like to have Dr. Canullo's short CV for all of you, and then we will straightly go to the presentation, and then we will have for sure a great discussion on the topic. So Dr. Canullo graduated cum laude in dentistry and dental prosthesis at the University of Rome, La Sapienza, if I pronounced it right, in 1994, PhD at the University of Bonn, Germany, national and international speaker on surgical and prosthetic aspects of implant dentistry. He is the author of more than 100 articles published on international journals on topics related to implantology. He is the active member of Italian Academy of Osseointegration and European Academy of Osseointegration. He is also visiting professor at the University of Sacra do Coração in Bauru, Brazil, and awarded for the best clinical presentation at EAO in 2008. Martignoni at the Italian Academy of Prosthetic Dentistry in 2012. The best scientific article at the American Academy of Osseointegration in 2013, and clinical and basic research at the Italian Society of Osseointegration in 2016. His professional office is in Rome, and it's limited in private practice at surgery and implant-supported prosthetic rehabilitation. And the topic that he will talk about for us today is the management of post-extraction sockets in the aesthetic zone, which I believe is one of the challenging things that as a practitioner, we need to know about the details of it. So Luigi, we are ready from head to toe for your amazing presentation and looking forward for the discussion at the end.
Okay, I start. Let me share my screen. And let me start my presentation. Yes, today we will share my experience on how to manage post-extraction site in the aesthetic area. As you can see, I come from Rome, and this is, I mean, part of my heart. It's very beautiful. I really hope you will come here in the next future and you will visit us. Okay, let's go straight to the point. All you know that I am really focused on research, but I mean, research is just a part of our practice, everyday practice. I am basically a dental surgeon, an implantologist, I would say, and every day I face the challenging target, a challenging goal to restore anterior teeth, which is my most common treatment. Very often, aesthetics is perceived as a basic mathematical equation, a very easy mathematical equation, just because there are few variables. But even if there are few variables, aesthetics, which means the recreation of the osteomucoprosthetic framework, is not an easy equation. It's not a mathematical equation. It's very hard, at least because what we need is a very good which could give us the possibility to restore the teeth, the biomimesis, I say. In time, what our goal is to regenerate, to exploit Mother Nature in the characteristics, patterns, in the try to regenerate soft and hard tissues. And of course, even if now soft tissue became a very important, a very hot topic, still remains the biology. And the biology say us that the leading material, the leading structure still remain the bone. And that is my first aspect I will investigate. We will investigate together. Let's try to move to what literature show us. Essentially, the literature show us two different approaches for regenerate bone, for restore aesthetics in the anterior area. The first way is a delayed approach. The delayed approach essentially is based on regeneration, extraction, regeneration of the site, and then later insertion of the implant and eventually the prosthesis. On the other hand, on the other hand, there is a second approach, an immediate approach, which suggests us to restore the aesthetic area at the time of extraction, inserting the implant. You can see here a case given by my good friend Dr. Mesquida. Essentially, this approach suggests to remove the tooth, insert the implant, regenerate the bone, place the restoration, the provisional restoration, eventually increase the soft tissue appearance through a graft, and after osseointegration, the insertion of the definitive restoration. Yes, of course, all these approaches clearly works, but as I told you, I am a clinician, but I am also a researcher, and I spent a lot of time trying to understand the biology behind these approaches. And what I saw is that using an immediate approach, I mean, immediately inserting the implant, what we have, due to the position of the implant, is an emergence profile, an S-line, very huge. And my question is that kind of prosthesis easily cleaned by the patient? Second question, the position of the implant slightly palatal. Does obliterate the blood supply from the palatal aspect of the bone, which is supposed to be the bigger dispenser of the blood supply, which is a critical, a key factor for bone regeneration of the graft material inserted in the alveolus. And of course, the answer for both questions are yes. I'm not saying, of course, that post-extraction approach is wrong. What I'm saying, as my good friend Andrea Chiarico always show me, my personal perspective, my suggestion is that this kind of approach, even if it's working, my perception is that this approach is not the most, biological, okay? I feel this kind of approach a little bit over treatment, okay? In fact, from my perspective, implant inserted with a delayed post extraction regeneration is much more biological, because it allows the insertion of the implant not slightly palatal, but essentially mid-crestally, and which leads to a flatter emergence profile, which is, of course, much easier to be cleaned by the patient. Let's try also to understand the key factor for bone regeneration, okay? First rule for a good bone regeneration is that there should be a blood supply which is in contact, in direct contact with the graft, with the bone graft, which should have at least osteoconductivity. Then the third rule for a good key factors, even in case of post-extraction sites, which are supposed to be the easiest cases, and they are not, should be the absence of bacterial contamination. Because of course, if we contaminated our graft, the biological response of our body will be at least fibrointegration of the graft material, at least. Then, last rule for bone regeneration is that the graft should be stable, okay? Let's try to understand how I usually do this kind of approach. I usually respect these rules during my post-extraction site regeneration. Okay, obviously, first basic rule in the post-extraction site is that the extraction should be minimally invasive. Therefore, if it's a basic management of a tooth, I try to carefully and less invasively extract the tooth, not moving the tooth backally and palatally, in order to minimize the trauma to the buccal bone, which is, all of us knows it, the weaker part of the chain. Once I have extracted a tooth, I think that it's very important, and lately this kind of approach is a little bit underestimated, removing all the granulation tissue. And I do it using a piezo and a small curette. Of course, removing of this graft material, sorry, of this granulation tissue allows the material to be in perfect contact with the bone, and at the same time, using the ultrasounds allow to minimize the contamination of the site itself. Why it's important to remove the granulation tissue? The granulation tissue, according to our last study, showed a huge amount of epithelium and inflammatory cells. And even if this would be inert, of course, our body will take time to remove it. And of course, there will be a barrier between the blood supply and the graft material itself. Additionally, we have to be very aware of the fact this kind of granulation tissue is very often microbiologically contaminated. Therefore, what I usually do, I do have granulation tissue, is to remove, carefully remove this granulation tissue, using this granulation tissue for covering the graft material. I'm going to publish a study on this topic in the next few days. And this technique, according to my good friend Andrea Grassi, is called now upside technique. Once we have completely cleaned the site, of course, our main purpose is to fulfill the site using the graft material. If in the last years I used only graft material, now I'm spending a lot of time trying to mix the graft material itself by blood in order to better manage this graft material, better handle this graft material. In case of, we will see it, in case of critical sites, what I do, which means sites with no buccal bone or sites very huge, big, I usually mix the graft material using autogenous bone picked from different sites, in rural sites, using a bone scraper. Mixing the graft material and the autogenous bone 50-50, I would say. Recently, with my good friend Anton Scully and Mia Rakic, we have seen that we can even bioactivate graft material, which means increase the surface energy and at the same time increase the wettability of the graft material, which of course resonates in a huger, bigger, more massive cell to graft material contact, which of course leads to a better and more qualitative bone regeneration. As we can see in this study we have done with my good friend Xavier and Daniele Botticelli. Once we have to respond to the third law in bone regeneration, which is waterproof the graft material, avoiding any contact with the oral contaminated environment. We have to take care of how the soft tissue can be sealed. And there are several techniques. The easiest way, the one I used till, 2 years ago, and I still in the posterior area, is the collagen sponge. Even if I can use also a plastic collagen matrix, or lately, but we can discuss on it, EPTFE membranes. Now, very recently, mostly in the aesthetic area, which is the topic of our meeting today, actually use autogenous connective tissues. Once we have set the graft, what I do to take a punch of palatal area, I would say a stamp, a small stamp, and I suture all around with 6 and even 7 zero sutures. Of course, that is possible when we have a very thick biotype. When we do have a thin biotype, what we have to do is to take an envelope, a very huge graft material, which should be enveloped backly and lingually. Then we have to talk about the graft stability. Of course, in the aesthetic area, we have also to consider the aesthetics. We cannot leave our patient without a central incisor. So the easiest way to me is to perform a Maryland bridge. For such a long time, I spent time in performing a Maryland bridge with an ovatic pontic. But what I've seen recently is that this kind of design prevents soft tissue from a perfect healing. As we can see here in the black and white pictures, just in the red area. Now my approach is to use a flat design Maryland bridge, which allows a perfect soft tissue healing, which of course will be maybe later during the first surgery, during the implant insertion, moved backally to prevent buccal recession or buccal concavity. Then, of course, we have to talk about the graft material. What we can say is that the last systematic review by Professor Sanz showed that essentially we have 3 different classes of graft materials. The first one is, of course, the most studied, the proteinized animal matrix. Second one is the industrial matrix, the hydroxyapatite produced by the companies. And lately, as my good friend Dr. Abundo showed me, there are the sugar-based matrix, which at the moment will be my perception is that will be the future. But let's see later. Okay, once we have seen that the post-extraction site is a complicated bone regeneration, let's try to focus our attention on the different scenarios. Yes, of course, we cannot use the same approach for every cases of post-extraction sites. According to what the New York University group showed us, we have 3 possible scenarios, clinical scenarios. The first one, the so-called type 1, is when we have soft and hard tissue, mostly intact material. Yes, this is the easiest way, and being the easiest way, we can use the easiest technique. But sometimes we do have to face a more complex case, the so-called type 2, when the buccal bony wall is completely deficient or partially deficient. In this case, we can use the same technique, but we have to add some boosters. Last but not least, we have to face cases where the post-extraction additional bone regeneration is not possible. It's the case 3, where the buccal and the buccal bony wall and the soft tissue wall are deficient. In this case, the only approach we have is to delay the bone regeneration using traditional approaches. Let's try step by step, see what I usually do in my practice. This is a young lady, highly demanding young lady, which have, I mean, an hopeless tooth due to the external deficiency of the root. Tooth was extracted, post-extraction site was cleaned, bone graft was inserted, traditional bone graft was inserted, and then the sealing was performed using a very small line, very small film of collagen. And of course, the stability of the graft was ensured by Marilyn bridge. And that's what we had after 3 months. A completely regenerated graft material, sorry, post-extraction site, which can be easily approached using traditional old style, I would say, guided implant insertion. In this case, it was done almost 10 years ago. A small flap was raised. The implant was inserted specifically mid-crystal. Then the implant, and this is one of the newest implant in the produced in Italy, so-called Prama, was placed, and then, due to the fact that stability was very good, was provisionally restored. When I do this kind of restoration, I try to finalize my provisional restoration following the following rule, following these rules. I design the zenith, the buccal zenith, but I try to minimize the mesial and distal area compression, allowing the papilla maturation. Once the soft tissue were matured, the easiest way was to take an impression and paste and copy what the provisional restoration did. And that was we reached with my technician, which studied a lot the aesthetics, inserted definitive abutment, zirconia abutment. Then we designed the shape of the crown. In this case, we used completely full ceramic crown, and that was the outcome at time 0. Okay, aesthetic was enough good. Of course, the papilla maturation, the papilla was not complete, but let's see what happened 5 years thereafter. You can see that the buccal architecture, the buccal bone wall architecture was perfectly restored, and of course this reflect on the soft tissues, which were, I mean, enough good. Unfortunately, the patient was the patient aspiration was completely fulfilled. Let's try what happened in case 2. Okay, which means when we do not have the buccal bony wall. Surgical approach is more or less the same. However, some small changes in this case should be done. And we have to consider to use boosters to improve the quality of regeneration. The first booster, once we have removed, once we have extracted the tooth and we have cleaned the alveolus, is of course using a boosted graft material, a graft material with more or less osteoinductivity characteristics. And in this case, I use mixture with the graft material and autogenous bone. 50-50 once again, and the autogenous bone was collected from very often from the retromolar area. Once we have set all the graft material, I usually put a very thin layer of collagen, and then I graft a palatal epithelial connective tissue graft, and I suture it with 6-0 sutures. Then we wait for traditional times, I mean for traditional healing period, and that is the result. After 3 months, after 3-4 months, we do have a clean and completely regenerated area, even though it was a critical area. I usually plan the surgery through a computer planification program. And of course, I do perform guided surgery. But before this, I spent some time in focusing on the soft tissue management. In this case, there was a defect of eruption. So as we can see in these pictures, I try to remove some tissue from the central incisors. Then I designed a very small trap in the buccal area, and through this small flap, I inserted the implant. Okay, I repositioned these 4 millimeters of graft tissue buccally in order to increase the concavity of the buccal area. Then I inserted the implant, and at the same time, I asked my good friend Riccardo Perpetuini, who is a fantastic conservative guy, to restore the zenith of the incisal anterior teeth. And that's what we have after a few days. The implant was inserted. The zenith were completely redesigned. And then the easiest way is just to ask the technician to prepare a nice provisional restoration in order to help Mother Nature to mature the soft tissues. And that's what happens. Once the implant was inserted, I manage the soft tissues. And once the soft tissues correspond to my idea of aesthetic, I just ask the technician to reproduce the perfect aesthetics in my patients. And that's what we have 2 years thereafter. Radiologically and aesthetically, a good case. Another case where I do ask something more to my procedure is a case like that, where we do have a very thin biotype, which of course will result in a huge shrinkage of the buccal dimension. In this case, I try to make my procedure a little bit earlier, after 2 weeks, after 2 months, which means when the graft material is not completely osteointegrated. At this time, the healing period corresponds to the reconstruction of bone islands included in a very huge amount of connective tissue, which will become bone. But at this time, this bone is very elastic, and for this reason can be expanded using sponsors, usually osteotome or magnetodynamic technique. Of course, I do usually perform a guided surgery. I just prepare the first drill, and then I expand with the osteotomes, and then I enter the implant. And at this time, if I do not have, which is very common, a complete stability, what I do is I take an impression, I suture, and after 3 weeks, please look at the reconstruction of the buccal site. At this time, I've reopened the implant. I insert the customized abutment. In this case, I use a bioactivated abutment, which makes the abutment more wettable. And then, once I've inserted the abutment, I try using one abutment one time to modify the soft tissues using only the provisional restoration. And that's what we have at time 0, and that's what we have 8 years thereafter. So that's what I usually do. If you give me a few seconds, I'll try to fill you up an additional cases. Sorry. This is another case. I mean, a little bit more complex. A case where the tooth was completely fractured. Of course, in this case, the most important thing is to completely remove the granulation tissue.
The screen is not shared.
Then, oh, sorry. Is that better? I suppose so. Okay, so this is a case where the starting conditions were a little bit more complex. Fractured tooth, which completely involved the buccal bony wall. The tooth was extracted. The socket was completely cleaned, and then a composite graft material, autogenous plus artificial graft was inserted. Then was a connective tissue layer was set, and then epithelial connective graft was positioned. And that's what we have after 2 months. Okay, the bone regeneration was completely performed. The soft tissue was healed, and then what we have to do is just to insert the implant using a traditional approach. In this case, we performed palatal incision in order not to destroy the thin soft tissue layer we have created before. Then we inserted the implant using a guide, always placing the implant in the central mid-crestal position. Then we resecured the flap, the minimal flap, trying to expose only the the neck, and then a definitive abutment was placed, and a provisional restoration. Provisional restoration was seated using a traditional approach, taken from the traditional prosthesis. We manage soft tissue using micro addition of a composite. And once we have reached the final definitive position of soft tissue with a very good soft tissue response, what we do is just to copy and paste what we have done. That's what we usually do. And once we give the technician all the keys for performing definitive abutment and definitive restoration following what we have reached before, the game is over. Of course, we need a good technician, which, as I mentioned at the beginning, is an essential part of our goal. That's what we do. This is time 0. Even in this case, I asked my good friend Riccardo to modify the design of the lateral incisor in order to achieve a better aesthetics. And then I treat the patient as it was a normal tooth. I take the impression, I check the fit of the definitive restoration, I check the color, and then I simply cement the crown. This is the 2-year follow-up. And then this is the 3 years follow-up. Soft tissues are very good, and soft tissues in my case is my key to check if everything is fine. Okay, I'm done. I really hope, yes, I am on time, fortunately. Okay, so now it's up to you.
Yeah, thank you, Luigi. Thank you for the comprehensive presentation. Actually, you started from the very basic things that we should know and showed us all the way to the more compromised cases and how to deal with them and how to give the patient the final aesthetic outcome as great as possible. So, as you said, it's a fun part of our hot seat, and I would like to have some comments from you and some questions from me that I really really looking forward to know your answers about them. The first thing that you mentioned was regarding when you compared healed site with immediate placement of implants. And as you showed in your type 1 and type 2 socket management, in some cases you prefer to go with immediate placement, and in some cases you prefer to go with a stage approach. But as I remember in the first part of the presentation, you mentioned that you prefer to go with the conventional approach and let the ridge heal, so make you able to place your implant in an incisal edge position, not in the cingulum position. So your main concern was about S-line. Your main concern was about that S-line and that the patient may not be able to clean the area and etc. So I want to know if you place your implant in the palatal position, in the functional cusp position like cingulum, and you place your implants a little bit deeper, then the technician have the chance to go very slowly to the top and not making it very severe S shape, but more beveled one. Do you agree that that concept make patients being able to clean better, or at least make tissue attachments more properly, or not?
Okay, now you are open a black hole. Okay, ready to wait for my answer. I think that the deeper crystal positioning of the implant requires much more attention. The first attention should be about the connection. For what I know, no connection can be completely seal any company can provide melted connection, cold melted connection, and every connection presents some sealing, some open points where bacteria can go on and out. Therefore, this put the problem a little bit later, maybe in 3, 4, 5 years. Additionally, inserting the abutment much deeper, you need an abutment absolutely cleaned. And for what I know, very often the abutment we mount, even if it comes directly from the company, are polluted. I did lots of studies which showed this, and also some other important speakers showed. Try to think on what happens after customization of the abutment. A very huge amount of microparticles, titanium microparticles, metal microparticles, oil microparticles, and every kind of pollutants. Were put just at the critical position between the bone and the connective tissue, which to me is very dangerous, very dangerous. This is my position, of course, and I mean, I really know that better surgeon than me are expert on immediate position. I feel more comfortable. Let's say I feel much more comfortable doing things respecting biology. Okay.
And speaking of that, when you place your implants immediately, when you are in cases you place your implants immediately in the extraction sockets, do you also place the implants under the incisal edge?
I do use as a reference the CJ line, and I mean the buccal bony edge of the contralateral incisor, and I put the implant, the rough part of the implant 0.5 millimeter below the counterpart. This is my reference. This is my reference. Yeah, below the counterpart, below the bone.
And in cases of that you want to do the grafting in the gap to make sure that the area is completely sealed, do you graft up to the crestal bone or up to the soft tissue?
No, up to the crestal bone. But again, that's what I do without the implant. Okay. I would say that if I treat 100 cases, 99 are post-extraction sites, are delayed post-extraction implants. One, and I mean, I'll try to follow the biology even in this case. If I put graft material over the bone level, I expect to have connective tissue grafted material. I mean, you can easily see what happens. Rising the flap, you find connective tissue with small particles of graft material, which I usually remove from my surgery. So I do not see it very useful for our treatment.
Yeah,
I much more prefer insert a graft material. Sorry, a connective graft material.
Yeah, and you
connective light graft material.
I noticed that you are a great fan of placing autogenous soft tissue graft on top of the extraction socket, like a free gingival graft or epithelial connective tissue graft. So one of the concerns that most of the clinicians may have with that procedure is that some will face the necrosis of that piece of tissue on top of the extraction site. I wanted to know your recommendations about the proper thickness of that tissue graft that they want to harvest and place in the area to prevent the necrosis in healing period.
Yeah, thank you for this question. You got the point. The point is the thickness not only of the grafted particle, but of host site. If you do have a thick biotype, which means 3-4 millimeter of thickness, then you can take a stamp of connective tissue, and then you can directly suture. If you do have a thinner biotype, which is very often, very common, you have to envelope the graft material buccally and lingually. That's what I suggest. Yeah, that's it. That's it. That's it. Trying to leave the central part still epithelialized. This is the easiest way to avoid any necrosis.
Yeah, and in
I mean, in the aesthetic area, yeah, in the aesthetic area, I found it very comfortable, very comfortable.
Mhm. And you know, one more thing that I wanted to ask you was that, especially in your last case that you showed us, it was more compromised case, the central one. When you place your implant under the incisal edge, you will have a very, very thin buccal bone remaining in the area. So don't you have any concern for future remodeling and soft tissue recession and exposure of the color of the abutment or etc.? Because I noticed, especially in the final case, uh, it seems that it was too facial regarding the thickness of the tissue or the bone available. So I want to know, in your experience, did you face
Okay.
uh, problem in long term or not?
Okay. Probably the picture you have seen was misleading, because you have to consider that the implant I used is a tissue implant, okay, with a conical neck, which means that what you see is just the apex of the neck. Try to think additionally that I always put the implant through guided surgery, and I always be very careful to insert the implant at least 1.5 mm, even 2 mm away from the buccal border. Okay, so I'm pretty sure, I'm sorry I do not have the possibility to show you up the CT, the CBCT, but I'm pretty sure that all my cases have the implant 2 mm away from the buccal bony border. Okay, so there are at least 2 mm.
Yeah.
Which is, of course, I follow the biology. I'm not such a good surgeon. I just follow the biology. And of course, if you have less in the future, you will have a remodeling, period. No possibility to escape biology.
Yeah. And Luigi, my final question for you. I'm really enjoying talking with you, and because there's so many informations out there. But my final question was that you talked about the one abutment, one time concept, and usually you decide to place the final abutment, the definitive abutment, like 3 days after the surgery or even at the time of the surgery. I want to know how you choose your final abutments regarding the position of the margin of the abutment comparing to the gingival level. Do you use the margin of the abutment? Do you want to place it at the level of the gingival, 1 mm below, 2 mm below? So what is your criteria in choosing that definitive abutment at the time of surgery?
Okay, thank you for the question. You, of course, got the right point. The right point is that when you use one abutment, one time procedure, you are blind at least on the soft tissue margin. And for this reason, together with Roberto Chetto and Ignazio Loi, which were my main inspirators, we wrote the book you have mentioned at the beginning. And in the book, we try to explain how to manage shoulderless abutments. And shoulderless abutment is the answer to your question. I mean, not having any margin, you are free. You are free to manage a soft tissue using the so-called BAT technique, which I usually teach in my courses, which is, from my perspective, another key point for obtaining successful cases.
Mm-hmm.
Of course, it's completely different from traditional approach, but from my personal impression, from my personal clinical experience, this kind of approach allows you to design the soft tissues. You design, you want a soft tissue upper, I put some more material. I want the soft tissue below, I just off the crown tissues.
Mm-hmm.
So it's the easiest way to obtain aesthetics. You can increase or decrease the volume and the height of the soft tissues this way. So maybe in the next future we can talk even about this technique, which from my point of view, from my experience, is a revolutionary approach. And for every young, not experienced surgeon, my suggestion to all the young people, but also for the more expert ones, is try to think biologically, that try to open up your overview and please approach BOPT.
Yeah, so the key factor was shoulderless abutments, right?
Yeah. So what you can see, what you can do is just to follow the soft tissue healing. So you do not anticipate the soft tissue healing. You just see how, and you modify. Eventually, you modify the soft tissue healing.
Yeah, Luigi, thank you so much, my friend,
Okay.
for joining. I really
Thank you. It was a.
I hope you stay well, and I hope to see you very soon. And God bless you. Hats off.
Goodbye. Ciao.
Ciao.